If you're over 40 and you climb a flight of stairs and your chest suddenly feels like someone is sitting on it, and then you stop and the pain goes away, congratulations, you already have plaque in your coronary arteries. That is not a metaphor. That is heart disease, already in progress, right now, inside you. And most people will ignore it for another 5 years until it kills them in their sleep or in a parking lot. Stick with me for the next few minutes because I'm going to walk you through exactly which warning signs mean make an appointment next month and which ones mean go to the emergency room tonight. And then I'm going to show you, step by step, how to take a dangerous, unstable plaque and turn it into a stable, boring, harmless one that you can live with for decades. This is the conversation cardiologists wish they had time to have with every single patient over 40 and almost never do.
Let's start with the chest. You're shoveling snow or you're climbing to the 3rd floor, and out of nowhere, your chest starts to burn or feels squeezed. You stop, you put the shovel down. A minute later, the pain is gone. A lot of people tell themselves that's just being out of shape. It isn't. That pattern, pain with exertion, relief with rest, is the textbook definition of stable angina, and it means you already have plaque narrowing your coronary arteries. That's coronary artery disease. You need a cardiologist, and you need one soon, not eventually.
The brain version of this is sneakier and, honestly, scarier, because the warning is so small that most people never even mention it to a doctor. Maybe your thinking feels a little foggier than it used to. Maybe for 30 seconds, one hand goes weak. Maybe one side of your face droops just slightly, or your words come out garbled, like your tongue forgot how to cooperate. And then, just as fast as it started, it's gone, and you go back to your day like nothing happened. That is a transient ischemic attack, a TIA, often called a mini-stroke, and it is your brain sending you the loudest possible warning shot before a full ischemic stroke. If that has ever happened to you, even once, even for 30 seconds, you need an ultrasound of your neck arteries or a CT angiogram immediately, not next week.
And then there's the one almost nobody talks about, your legs. You're walking, and somewhere around 200 or 300 yards, sometimes a bit farther, your calves start to burn or cramp, the way they would after a brutal leg day at the gym. You stop, you rest for a minute, the burning fades, and you keep walking. That's called intermittent claudication, and it means the arteries feeding your legs are narrowing too. This needs a vascular surgeon, an ultrasound of the leg arteries, possibly a CT angiogram. Here's the part that should genuinely scare you. Everyone is terrified of heart attacks and strokes, but almost nobody knows that once leg artery disease progresses to gangrene and an amputation becomes necessary, the 5-year survival rate is around 10%. People simply cannot psychologically adjust to losing a limb, and they decline shockingly fast at home afterward. An amputation from poor circulation is statistically more lethal long-term than a lot of cancers people are far more afraid of.
So those are the 3 red alert symptoms. Chest pain with exertion that resolves with rest, brief neurological symptoms that come and go, and leg pain that forces you to stop walking. If any of those sound familiar, this is not a someday problem. But I also don't want you panicking right now and Googling your way into a spiral. Plaque is manageable. It is treatable. The goal of the next several minutes is to show you exactly how to manage it, stabilize it, and keep it from ever becoming the kind of event that ends up on a hospital chart with your name on it. Cardiovascular disease is the #1 killer in every developed country on Earth, ahead of every cancer combined. Taking care of your blood vessels is, without exaggeration, the single highest leverage thing you can do for your own lifespan.
I work as an interventional vascular specialist. I operate on the blood vessels of the heart, the brain, the legs, basically anywhere in the body that has a blood supply. Because anywhere there's a blood vessel, there's potential work for someone like me, opening things up, closing things off. A mentor of mine used to put it bluntly: an interventional vascular specialist is a plumber first and a doctor second. So let's talk about atherosclerosis,
plaque buildup in the arteries because it is simultaneously one of the most dangerous diseases out there and one that, statistically, comes for almost everyone eventually.
Pathologists will tell you this plainly. By the time someone reaches their 60s, it is essentially impossible to find an autopsy where the aorta shows zero atherosclerosis. When a pathologist opens up the aorta of someone young and runs a scalpel along the inside to clear the blood away, the lining is smooth, pale, almost satin-like. In someone past 60, that same lining is studded with yellowish deposits, plaques, and when you cut through it, you can actually hear and feel a faint crunch from calcium deposits. That calcium tells you the plaque has been sitting there for years, sometimes decades. By that age, the entire aorta is typically carpeted in these plaques. The hope is that none of them have ulcerated or ruptured, but sometimes they have, and that rupture is exactly what triggers a heart attack or a stroke.
Here's the good news. Finding a plaque on a scan is not a death sentence. It happens constantly. Someone gets a routine neck ultrasound, the tech finds a 30% plaque, and the patient spirals into panic, convinced a stroke is imminent, frantically searching for a surgeon to operate immediately. That reaction is almost never warranted. Before we go further, let's actually understand how a plaque forms in the first place and what triggers the whole process.
After more than a decade specializing in vascular disease, here's the pattern that shows up over and over. Roughly 40% of patients are smokers, another 40% are diabetics, and the remaining 20% is everyone else combined. Two factors dominate everything. The first is smoking. The toxins and tar that enter the bloodstream injure the artery wall day after day, cumulatively, like sandpaper on the inside of a pipe. The second is diabetes. Chronically elevated blood sugar essentially turns your blood into syrup, and that syrupy, sugar-coated blood damages the proteins lining your vessel walls with the same relentless daily injury.
And cholesterol, the most demonized molecule in modern nutrition, is actually the emergency response team showing up to patch the damage. When the vessel wall gets injured, cholesterol arrives like spackle, plastering over the wounded section to protect the integrity of the vessel. There's also a bad version of cholesterol we'll get to. But the point is, cholesterol isn't the villain who broke in. It's the repair crew showing up after someone else broke the window. So what do you actually need to do? Eliminate the things doing the damage in the first place. Plaque formation is a genuinely complex process, and hormones play a massive role in it. When a woman enters menopause, her cardiovascular risk profile essentially converges with a man's almost overnight. Atherosclerosis starts developing in earnest the same way it does in men. Before menopause, women carry a significant hormonal shield. Men go through an equivalent, much quieter hormonal decline too, andropause. It's just far less talked about and far less obvious. As hormone levels drop, that protective youth shield fades for men as well, and atherosclerosis starts showing up. Add to that the fact that men, historically, have been heavier and more frequent smokers, and you've got a second major risk factor stacking on top of the first.
So, day after day, year after year, the vessel wall takes damage. Cholesterol shows up to patch it. The patch gets patched again, and slowly the inner space of the artery narrows. Early on, that plaque is stable, basically dormant. The genuinely dangerous moment is when the plaque becomes inflamed, turns soft and unstable, and its outer cap ruptures, like a ripe watermelon splitting open. Your body interprets that rupture exactly the way it would interpret a cut on your finger, an open wound that needs to be sealed immediately. So it does what it always does with a wound. It forms a clot right there to stop the bleeding. Except this clot is now sitting inside an artery supplying your heart or your brain. And that clot is what actually triggers the heart attack or the stroke, not the plaque itself.
There are technically ischemic events affecting almost every organ. You can even have an infarct of the kidney. But the two that matter most, the two that kill people every single day in massive numbers, are heart attacks, myocardial infarction, and ischemic strokes, essentially an infarction of the brain. In any reasonably sized city, there's a cath lab running around the clock every single day handling these emergencies. A single heart procedure for a heart attack can run in the tens of thousands of dollars. A stroke intervention can run even higher. These labs perform up to 10, sometimes 20 procedures a day for heart attacks and strokes alone, nonstop, 24/7, every day of the year. The system working behind the scenes to save people from this disease is enormous. Most people simply never see it until they're the one on the table.
So how do you avoid ending up there? How do you keep your plaque from ever rupturing in the first place? It starts with screening. The most accessible window into the state of your entire vascular system is a simple ultrasound of the neck, specifically the carotid arteries. Here's the mechanism. Blood normally flows in smooth, layered streams. But at any point where an artery branches or forks, that smooth flow becomes turbulent. And turbulence causes extra wear and tear on the vessel wall at exactly that junction. That's precisely why plaques tend to form at branch points. And the carotid artery, where the common carotid splits into the internal carotid, feeding the brain, and external carotid, feeding the face, is one of the most accessible and most informative branch points in the entire body. A simple ultrasound probe placed on the neck lets a clinician directly assess the vessel wall thickness and check for any plaque. If a plaque or any thickening of the vessel wall shows up, the next step is blood work.
You'll want a full lipid panel. Not just total cholesterol, but HDL, the good cholesterol, LDL, and VLDL, the bad, oxidized cholesterol. There's also a newer marker, lipoprotein A, often abbreviated LPA. Unfortunately, it isn't part of standard public health screening panels in most places, but private labs offer it, and it has recently been added to European clinical guidelines as one of the single most important risk markers for atherosclerosis progression. An elevated LPA is, on its own, considered a strong indication for starting statin therapy.
So which type of cholesterol are we actually fighting? LDL and VLDL, the bad forms. If those are elevated, there's a real arsenal of treatment available. The most famous and most feared are statins. We'll dig into why that fear is mostly misplaced in a minute. There's also a class of drugs like ezetimibe, which work differently. They block the absorption of cholesterol in the gut rather than reducing its production. If your LPA isn't elevated, ezetimibe alone can be a reasonable starting point. Here's how it works. Cholesterol gets excreted into bile, travels into the intestine as part of digestion, and then a good portion of it gets reabsorbed back into the bloodstream because your body genuinely needs cholesterol. Any biochemistry textbook will open its cholesterol chapter with some version of cholesterol is essential to life. It's the literal building block of every cell membrane and every sex hormone you produce. It is not the enemy. But once atherosclerosis is established and your bad cholesterol is elevated, lowering it becomes medically necessary regardless. Ezetimibe blocks that intestinal reabsorption step, and on its own, it can cut LDL roughly in half with almost no meaningful side effects. That makes it a great first option for someone with borderline high cholesterol but no established plaque yet, or for someone who is dead set against ever taking a statin.
Now, statins. Why do they have such a terrifying reputation, blamed for everything from muscle pain to Alzheimer's to dementia? It's worth being honest here. There is research suggesting that long-term statin use may, in some populations, be associated with accelerated cognitive decline. But here's the blunt truth. If you don't start statins when you need them, you are statistically unlikely to live long enough to develop dementia or Alzheimer's in the first place, because a major cardiac or cerebrovascular event will get you first. Statins and atherosclerosis are, without exaggeration, among the most heavily researched subjects in all of modern medicine. Thousands of randomized controlled trials, decades of data, every individual statin molecule studied independently. The evidence base here is enormous.
So why the fear? Most people's first real encounter with statins happens after something has already gone wrong. Unstable angina, a pre-heart attack warning sign, an actual heart attack, or a small first stroke. Clinical guidelines, in that scenario, call for the highest available statin dose, precisely because the goal isn't just lowering cholesterol numbers, it's actively reducing inflammation in the plaque itself. That anti-inflammatory effect is arguably statins' most important property. A calmer, less inflamed plaque is far less likely to crack open, form a clot, and trigger another heart attack or stroke. So high-dose statins after a cardiovascular event are standard practice, specifically to prevent a second one.
At high doses, two side effects show up most often: muscle aches, a deep flu-like soreness, or the kind of ache you get after overtraining, and some mild liver enzyme elevation, AST and ALT, on blood work. In most patients, both of these settle down as the body adjusts, or your doctor can switch medications, or move you to a combination of a lower statin dose plus ezetimibe. That combination, low-dose statin paired with ezetimibe, often delivers excellent cholesterol reduction and inflammation control with a much gentler side effect profile, which matters enormously for keeping the plaque from progressing or rupturing.
Bottom line, the side effects people fear from statins are typically mild and manageable, while the dementia and Alzheimer's fear is, frankly, a luxury problem. Because if you've already got significant plaque and you skip the medication that controls it, the odds of surviving long enough to develop those conditions drop sharply. There's a dark joke in cardiology that whoever doesn't die of a heart attack or stroke eventually dies of cancer. And there's more truth buried in that joke than people realize. Patients with well-managed cardiovascular health genuinely do live long enough to face other diseases later in life, cancer included. Let's pause the medication discussion and talk about what actually accelerates plaque growth. Because lowering cholesterol and stabilizing existing plaque is only half the job. You also have to eliminate whatever's actively damaging the vessel wall in the first place.
We already covered smoking. It is one of the most exhaustively documented causes of cardiovascular disease, lung cancer, throat cancer, and a long list of other conditions. Next is diabetes. That blood turning into syrup effect causes both microvascular and macrovascular damage. Kidneys fail, eyesight deteriorates, and the large vessels take damage too, accelerating plaque formation and raising heart attack and stroke risk. But here's something genuinely surprising from a large study published last year comparing diabetes, smoking, and high blood pressure across a population of roughly 60,000 people. High blood pressure came out as the single most dangerous factor of the three. Hypertension is sometimes called the silent killer for exactly this reason. Blood pressure climbs gradually, and your body simply doesn't register it as a problem. Plenty of people walk around at 150/90 or even 160/100 and insist they feel completely fine. Doctors even have an informal term for this, working pressure, meaning the patient has essentially adapted to chronically elevated readings and actually feels worse, dizzier, weaker if you bring their blood pressure back down to a normal range. Despite feeling fine, elevated pressure turns out to be the single biggest driver of vessel wall damage and plaque formation in that research. Think of a garden hose under constant excess pressure. If that hose could adapt, it would start reinforcing itself, trading flexibility for rigidity to avoid bursting. That's essentially what your arteries do under chronic high pressure. They stiffen, lose elasticity, and respond differently to the pulse wave coming from your heart and to physical exertion. That loss of elasticity creates exactly the kind of mechanical stress that promotes plaque formation. What else accelerates the whole process? Excess body weight. Carrying extra weight sets you up for cardiovascular disease earlier, partly because fat tissue itself functions as an active hormone-producing organ. It's now well established that fat tissue disrupts the body's hormonal balance, including converting and metabolizing sex hormones in ways that throw the whole system off. Excess weight also forces the heart to work dramatically harder.
Picture someone who, at a given height, should weigh somewhere around a normal, healthy range, but instead weighs nearly double that. That heart now has to pump blood to support, in effect, 2 or 3 people's worth of tissue. Eventually, the heart simply can't keep up. There are documented cases of hearts physically deteriorating, not from any other identifiable condition, purely from the chronic mechanical overload of carrying excess weight for years. On top of that mechanical strain, excess weight typically brings elevated blood sugar, elevated insulin, fatty liver disease, and a cascade of metabolic dysfunction. Excess weight isn't a cosmetic issue, it is functionally a chronic disease state, and fat tissue itself drives chronic low-grade inflammation throughout the body, including inflammation inside existing plaques. Which brings us to factor number 5, inflammation, more broadly. This means taking dental and oral health seriously. Untreated cavities, chronic sinus infections, any persistent bacterial or non-bacterial inflammatory focus in your body. These all feed systemic inflammation, which in turn can inflame existing plaques and raise your risk of a cardiovascular event. There was a striking study done in the UK around a decade ago when mechanical clot removal procedures for stroke were just becoming routine, where researchers actually cultured the clots pulled out of stroke patients' brains. The results were remarkable. Somewhere around 60 to 70% of those cultures grew oral bacteria, specifically bacteria associated with dental cavities and gum disease. That suggests a direct physical link between untreated tooth decay and the clot that triggers a stroke. So, to recap the 5 major accelerants: smoking, diabetes, excess weight, hypertension, and chronic inflammatory foci. These are the 5 fronts you need to fight on to keep cardiovascular disease off your timeline. So where do you actually start, especially if you don't want to spend the rest of your life relying purely on pills? Physical activity matters enormously. We are living through an era of chronic metabolic overload, constant excess fuel coming in, almost no demand for the body to burn it off. Exercise fights diabetes, fights circulatory stagnation, fights inflammation. There's an enormous body of research behind the simple recommendation of 10,000 steps a day for stroke prevention and heart attack prevention. But it has to be a genuinely brisk walk, not a stroll. And realistically, that takes real time out of your day, an hour, 90 minutes. A relaxed evening walk along the waterfront with your spouse sounds wonderful, but most people simply don't have that kind of time or that kind of scenery available every single day.
So, is there a more time-efficient option? Absolutely. High-intensity interval training, which can be done in roughly 10 minutes. Here's a simple structure. 5 minutes of easy walking to warm up, then about 2 minutes of jogging, then a 30-second all-out sprint, scaled to whatever intensity is appropriate for your current fitness level. If you're not currently active, start extremely conservatively. 30 seconds of effort, 2 minutes of recovery walking. Repeat. These short, intense bursts trigger major changes. They ramp up your breathing, your blood flow, your lymphatic flow, and essentially force a full system reset. The entire session can take 10 minutes, and this style of training has become genuinely popular across the United States recently, with people reporting dramatic results, precisely because peak intensity, stress-driven effort triggers such a strong physiological response. If you can, hiring a trainer is genuinely worthwhile. Someone who pushes you, corrects your form so you don't get hurt, and keeps you accountable, because life's daily demands have a way of eating up the time we intend to spend on ourselves.
Unfortunately, physical inactivity is one of the defining plagues of modern life. We sit at our desks. We sit in the car or on the bus commuting to work. We sit through most of our waking hours. People have largely stopped doing physical labor, riding horses, hauling water, walking everywhere. And as physical activity has disappeared from daily life, chronic disease has exploded to fill the gap. There's also a specific breathing technique worth mentioning, a kind of deep abdominal vacuum breathing exercise that stimulates blood flow and lymphatic drainage, improves gut motility, and supports weight management, among other benefits. You can do it at home first thing in the morning, on an empty stomach. No gym, no equipment required. Honestly, the goal here isn't perfection. It's just getting you to start doing something. Anything. Because without that first step, nothing changes. One more critical point about exercise. Resistance training that produces real muscle fatigue has been shown to directly fight diabetes because it opens up what's sometimes called the insulin window. Your muscles temporarily become dramatically more sensitive to insulin, which means glucose gets pulled out of the bloodstream and into the muscle cells more efficiently. There are even rehabilitation programs that have successfully reversed a type 2 diabetes diagnosis using nothing but structured diet and muscle-fatiguing resistance training.
Temperature exposure matters too. Anything that forces your blood vessels to alternately constrict and dilate. Cold showers, cold water immersion, ice baths, all the cold exposure practices that have become trendy in longevity and recovery circles genuinely benefits vascular health. Cold causes your vessels to contract, which shifts circulation patterns, changes blood flow distribution, and changes your breathing pattern. All of that is meaningfully beneficial for vascular function over time.
Then there's the question of carbohydrates. We've already established that chronically high blood sugar damages vessel walls. Here's the thing. Even if you're nowhere near diabetic, even if your blood work looks completely normal, cutting back on refined sugar and fast-digesting carbohydrates still measurably improves how your liver functions and how every other organ system performs. And let's debunk the popular myth that your brain needs sugar to function. It's mostly nonsense. Yes, your brain is the body's largest single consumer of glucose for fuel, but your body is fully capable of manufacturing all the glucose it needs from protein and fat. And both of those are actually more energy-efficient fuel sources than carbohydrates, especially refined ones. Look at populations in extreme northern climates whose traditional diets contain essentially zero carbohydrates, not even slow-digesting ones. And yet they have some of the highest caloric energy expenditures of any population on Earth. Historically, that diet developed simply because carbohydrate-rich foods don't grow in Arctic environments, but it proves the body can run perfectly well on fat and protein alone. When you first cut sugar out, expect a genuine withdrawal period. It can feel remarkably similar to quitting a substance, because functionally, it kind of is one. There's even a probably apocryphal but telling story about early colonial trade decisions weighing whether to export sugar or cocaine from the New World, and settling on sugar specifically because unlike cocaine, you could market it to children, meaning a vastly larger built-in customer base. Treat that as folklore, not history, but the underlying point stands. Sugar is engineered, marketed, and consumed almost exactly like an addictive substance. Do whatever you reasonably can to minimize it in your life.
And we already covered chronic inflammation. Don't skip your dentist. Don't ignore that nagging sinus issue. Don't let any small chronic inflammatory problem sit untreated indefinitely. Resolve it with the right specialist. Your blood vessels will genuinely thank you for it.
So, when should you actually start screening for all of this? As a general rule, by your 40s, because that's roughly when your hormonal protection starts fading and decades of accumulated habits, whatever they've been, start catching up with you. Up until that point, youth and a robust hormonal system tend to paper over a lot of bad habits. After 40, that forgiveness runs out fast. So starting in your 40s, an annual checkup should include, at minimum, a full blood chemistry panel with a complete lipid profile, total cholesterol, LDL, HDL, and ideally LPA, plus an ultrasound of the carotid arteries in your neck, and ideally one of the leg arteries too. Stay consistent with that every single year, and you genuinely won't get blindsided. Most plaque-related cardiovascular events tend to cluster around age 50, which, not coincidentally, is roughly when menopause hits for women and the male equivalent hormonal decline hits for men. The majority of heart attacks and strokes happen right around that 50-year mark.
There's a memorable patient story worth sharing here. A man, exactly 50 years old, who was driving through on a road trip when he suddenly felt crushing chest pain. He was rushed in, and it turned out to be a major anterior heart attack. The procedure went well. He was stabilized, and afterward, recovering, he said something striking. "Doc, so I'm not going to die?" He was told no, he was going to be fine. They'd caught it and treated it. He explained that he believed his family was cursed. Every man in his family line had died of a heart attack at exactly 50. His grandfather, his father, his older brother, all at 50, all from heart attacks. And here he was, turning 50 himself, and it had nearly happened to him too. He was told, only half joking, that the curse was officially lifted. The real lesson in that story isn't about curses. It's that these events genuinely cluster around that age window, almost predictably, which is exactly why starting annual screening at 40 matters so much. It gives you a full decade of monitoring before you hit that statistical danger zone. It's also worth building an ongoing relationship with a primary care doctor or a cardiologist who tracks you year over year and actually knows your baseline.
One more piece that deserves real attention: stress and your overall relationship with your own life. Stress reliably drives blood pressure up. It drives people toward poor food choices, breaking diets, reaching for that extra dessert just this once, over and over. Stress gets talked about constantly these days, almost to the point of becoming background noise. But the physiological effects are completely real. Here's the part worth sitting with, though. At its core, chronic stress is often what happens when we're quietly lying to ourselves, staying for years in a job we don't actually want, staying in relationships that don't actually serve us. It's those daily, self-inflicted, unresolved tensions, the ones we, frankly, often build for ourselves, that wear us down from the inside, day after day, far more than almost anything external. So genuinely, build a life you don't need a vacation from. Learn to actually listen to yourself. Let yourself want things, and then go after them. That, as much as any medication or any lab value, is part of a long, healthy life.
Let's go a little deeper on the screening piece, because this is the part people skip the most, and it's the part that actually saves lives. A carotid ultrasound takes maybe 10 minutes. There's no needle, no radiation, no prep. A technician runs a probe along your neck, and within minutes, you know whether your arteries are clean or whether there's already a plaque sitting there quietly. Compare that 10-minute appointment to the alternative: an ambulance ride, an emergency catheterization, a hospital bill that can run into the tens of thousands of dollars, and possibly a permanent disability afterward. There is no version of this math where skipping the ultrasound makes sense. And yet most people walk past their 40s and 50s without ever getting one, simply because nobody told them it was something they needed to ask for.
The blood work side is just as important and just as easy to get wrong if you don't know what to ask for. A standard cholesterol panel at most routine physicals will give you total cholesterol, HDL, and an estimated LDL. That's a starting point, but it's not the full picture. Ask specifically for a direct LDL measurement. Ask about VLDL. And if your doctor's office or a private lab can run it, ask about lipoprotein A, LPA, even if it costs a little out of pocket. LPA is largely genetic. It doesn't move much with diet or exercise, and a high reading is one of the strongest independent predictors of plaque buildup we currently know about. If you have a family history of early heart attacks or strokes, especially anyone who had an event before 60, that's an even stronger reason to get this specific marker checked, because elevated LPA tends to run hard in families.
Now, let's talk about what a good set of numbers actually looks like. Because plenty of people get a lab report back, see the word normal next to a number, and assume they're in the clear. Normal for the general population and optimal for someone trying to prevent a heart attack are not the same target. If you already have any plaque on an ultrasound, or any other risk factor, diabetes,
hypertension, a smoking history, a strong family history, your LDL target is going to be lower than the standard reference range printed on a typical lab report. This is exactly the kind of nuance that a generic annual physical often misses, and exactly why it's worth finding a doctor who treats your numbers based on your actual risk profile, not just whether you fall inside a one-size-fits-all range.
It's also worth being honest about why so many people avoid this whole process in the first place. Nobody wants to find out they have a problem. There's a very human instinct to avoid the doctor, specifically because you're afraid of what they might tell you. But here's the thing about plaque. It doesn't care whether you know about it. It keeps building either way. The only question is whether you find out while it's still small, stable, and manageable with a pill and a few lifestyle changes, or whether you find out in an ambulance. Knowledge doesn't create the disease. It just gives you the chance to do something about it before the disease creates an emergency.
Let's also clear up a common point of confusion. A plaque showing up on an ultrasound is not the same thing as an active blockage requiring a stent or surgery. Most plaques discovered on routine screening are small, stable, and entirely manageable through medication and lifestyle changes alone. Surgery and stenting are reserved for severe narrowing, usually somewhere north of 70% blockage, or for plaques that are clearly unstable and at high risk of rupturing. Finding a small plaque is not a reason to panic or start hunting for a surgeon. It's a reason to start treatment early while your options are still simple.
So, let's put the whole plan together into something you can actually act on this week. First, if you're over 40 and haven't had a checkup in years, book one. Ask specifically for a full lipid panel and a carotid ultrasound. Don't assume your standard physical automatically includes either. Second, if you smoke, quitting is, bar none, the single highest impact change you can make for your vascular system. Full stop. Third, get your blood pressure checked regularly, not just once a year in a doctor's office where white coat anxiety can skew the reading, but periodically at home with an inexpensive cuff. Fourth, build some form of regular movement into your week, whether that's a brisk daily walk, a structured 10-minute interval session, or resistance training that leaves your muscles genuinely tired. Fifth, cut back on refined sugar and ultra-processed carbohydrates, not perfectly, just consistently. Sixth, take care of chronic infections. See your dentist. Treat that sinus issue you've been ignoring for 2 years. And seventh, if your numbers come back elevated and your doctor recommends medication, don't let fear of side effects you read about online keep you from a treatment with one of the largest, most reassuring safety records in all of medicine. None of this requires perfection. It requires consistency, and it requires getting the information in the first place, because you cannot manage what you haven't measured. The people who end up in the cath lab at 50, on a stretcher, hearing the word heart attack for the first time, are almost never people who knew about their plaque and ignored it. They're people who simply never checked. Don't be the person who finds out the hard way. Take care of your heart, take care of your arteries, and take care of yourself, starting today, not someday.